You're lying in a hospital bed. The monitor flatlines. In the next 60 seconds, things are going to happen to your body that nobody ever told you about. Let's start with what happens in the first 10 seconds. Your heart stops beating. Blood stops flowing. Your brain has about 10 seconds of residual oxygen before consciousness disappears. The cardiac monitor shows a flat line or chaotic rhythm. Ventricular fibrillation. An alarm screams. If you're conscious for those first few seconds, you might feel dizzy, your vision might tunnel, and then nothing. You're out. Here's what you don't see. The nurse hears the alarm and runs to your room. Within 30 seconds, someone should be at your bedside. They check for a pulse. There isn't one. They check if you're breathing. You're not. They slap the code blue button and yell, "Code blue." The announcement goes hospital-wide. Code blue, room 412. Now we're at the 60-second mark. Someone is already doing chest compressions. Here's what nobody tells you about CPR. It's violent. The person puts their hands on the center of your chest and pushes down 2 inches with their full body weight, 100 to 120 times per minute. They're pushing hard enough that your ribs might crack. You'll hear the sound, a crunching, popping noise as ribs fracture. This is normal. This is necessary. Here's the first revelation. Effective CPR breaks ribs in about 30% of patients. The compressions have to be hard enough to squeeze your heart between your sternum and spine, forcing blood out to your brain and organs. At the 90-second mark, the code team is arriving. A doctor, respiratory therapist, additional nurses, pharmacist, all sprinting to your room. Someone's recording everything, the exact time your heart stopped, every medication given, every shock delivered. Your bed is lowered flat. The backboard slides under you. Someone's cutting off your hospital gown with scissors. You're completely exposed. Here's what's happening to your body. Without a heartbeat, you're clinically dead. But CPR is buying time, circulating just enough blood to keep your brain cells alive for a few more minutes. Brain cells start dying after 4 to 6 minutes without oxygen. Every compression pushes oxygenated blood to your brain. It's only about 30% as effective as a normal heartbeat, but it's enough to prevent brain death temporarily. At the 2-minute mark, someone's bagging you, manually ventilating with a mask, squeezing air into your lungs between compressions. The respiratory therapist is preparing to intubate. The pharmacist is drawing up medications. The doctor is looking at the monitor to identify your heart rhythm. Here's revelation number 2. There are different types of cardiac arrest. If your heart is in ventricular fibrillation, quivering uselessly, you need to be shocked. If it's asystole, completely flat, shocking won't help. Let's say your rhythm is VFib. At the 3-minute mark, the defibrillator is being charged. Someone yells, "Clear!" Everyone steps back. The defibrillator delivers 200 joules of electricity through your chest. Your entire body convulses, back arching, arms jerking. Everyone looks at the monitor to see if your heart rhythm converted. Here's what the shock does. It stops all electrical activity in your heart, hitting the reset button. The hope is that when electrical activity resumes, it'll be in a normal rhythm. Sometimes it works on the first shock. Sometimes it takes multiple shocks. Sometimes it doesn't work at all. At the 4-minute mark, compressions resume immediately. Someone else takes over because the first person is exhausted. Effective CPR is physically demanding. The code leader is calling out orders. Continue CPR. Give 1 milligram of epinephrine. Prepare for another shock. Here's revelation number 3. Epinephrine, adrenaline, is given to constrict your blood vessels, forcing blood to your heart and brain. It can help restart your heart, but it also makes your heart more irritable. At 5 minutes, you're being intubated. The respiratory therapist tilts your head back, inserts a blade to see your vocal cords, and threads a tube down your trachea. You're connected to a ventilator now. Compressions pause for maybe 10 seconds, then resume immediately. Here's what's happening inside. Your brain is on the edge of irreversible damage. 6 minutes without adequate oxygen causes brain cell death. CPR is providing some circulation, but it's marginal. Every minute that passes, your survival odds drop and your likelihood of brain damage increases. At the 7-minute mark, you've been shocked 3 times. You've received 2 doses of epinephrine. Compressions haven't stopped except for brief pauses. Someone's putting in a central line, a large IV in your neck for better medication delivery. The code leader is considering other medications, amiodarone to stabilize heart rhythm. Here's revelation number 4. The longer a code runs, the worse your chances. After 20 minutes of CPR with no response, survival is under 10%. At 10 minutes, let's say something changes. After the 4th shock, your heart rhythm converts to normal. There's a pulse. Everyone stops compressions and watches the monitor. It's real. Your heart is beating on its own. Here's what happens next. You're not awake. You're deeply unconscious from the cardiac arrest and medications. You're on a ventilator breathing for you. Your blood pressure is probably low. You're being rushed to the ICU. The real question now isn't whether your heart is beating, it's whether your brain survived intact. Now let's talk about what happens if your heart doesn't restart. The code has been running for 25 minutes. You've been shocked 6 times. You've received every medication. Your rhythm went from V-fib to a systole, a flat line. The code leader says, let's run it for 5 more minutes, then we'll call it. Here's revelation number 5. The decision to stop CPR is based on medical futility. If there's no response after prolonged resuscitation, the code leader calls time of death and compressions stop. Here's what most people don't know. Only about 25% of patients survive cardiac arrest to hospital discharge. And of those who survive, many have neurological damage, memory problems, cognitive impairment, or remain in vegetative states. The patients who do best are those whose hearts are restarted quickly. Let's talk about what you might experience if you survive. Some patients report near-death experiences, seeing lights, feeling peace. Others remember nothing. They were unconscious when they woke up later. Here's what you'll face physically. Bruised and possibly broken ribs from compressions, a sore throat from the breathing tube, possibly burned skin on your chest from defibrillator pads, muscle aches throughout your body, confusion as your brain recovers. You might be in the ICU for days or weeks. Here's revelation number 6. Therapeutic hypothermia is now standard after cardiac arrest. Your body is cooled to 32 to 34 degrees Celsius for 24 hours to reduce brain damage. Let's talk about what caused your heart to stop, because that determines your prognosis. Heart attack. You'll need cardiac catheterization and possibly stents. Arrhythmia. You might need an implanted defibrillator. Each cause requires different treatment. Here's what happens in the days after. You're monitored intensively, continuous EKG, frequent labs, brain imaging to assess damage, neurological exams. Family members are warned that you might not survive, might survive with severe disability, or might recover fully, and nobody knows which for several days. Now here's the reality. Location matters enormously. If your heart stops in the ICU where you're already monitored, survival is higher. If it happens at home, survival is under 10%. In-hospital cardiac arrests have better survival because the code team responds within a minute. Here's the final revelation. Every code is different. Some patients are revived in 2 minutes. Others get 45 minutes of resuscitation with no response. Your survival depends on immediate recognition, immediate CPR, and a coordinated team doing everything right. What really happens if your heart stops in a hospital is a violent, desperate assault on death itself. Your ribs get broken. Your body gets shocked. Medications flood your system. A team fights to bring you back from clinical death. It's not peaceful. It's brutal, exhausting, and often unsuccessful. But it's the only chance you have. And for the 25% who survive to leave the hospital, it's a chance that makes all the violence, all the broken ribs, and all the chaos absolutely worth it.